Hi, I'm Dr. Omar Danoon, and today we will talk in depth about drug-resistant epilepsy, which is epilepsy that does not respond to medications. And we'll talk in details how to make the diagnosis, how to do the treatment, what testing needs to be done, and all these details. And we'll answer all of your questions. So welcome today. So we'll start first by talking about the definition of drug-resistant epilepsy. The definition of drug-resistant epilepsy is when at least two medications that fails to control the seizures, when these medications are appropriate for dosing, appropriate for the type of epilepsy, and were given for a long time, which is appropriate timing. All of that fails to control the seizures or have sustained seizure freedom, which means that by this definition means that if seizures continue despite being on two anti-seizure medications that are really good for the type of epilepsy, and then they are used in high enough doses and they stay for long enough time to control the seizures, and despite being there, they did not control the seizures. They can be in isolation, means like one medicine alone and the second medicine alone, or they can be in combination. Most of the time, we have multiple medications that fails to control the seizures, and this is the definition of drug-resistant epilepsy. So this is something we always have, especially in epilepsy centers when we have complex cases. Before we dive deep into that, tell me, where are you watching us from? So I would love to know where you're watching us from, which country, which state, and we will answer all of your questions. So write down your questions, and we will answer at the end of the session. So tell me now, where are you watching us from, which country, which state, and we move on. Hey, we have from India. Welcome. A few Southampton from UK. One of my professors was a graduate from the university in Southampton. So welcome in UK. Welcome from Australia. Thank you so much. It is late today now in Australia. From Southern USA, welcome. In Southern USA, from Little Italy, welcome. From UK, welcome everyone. From the USA, welcome. DG Shuman. From USA, from Pakistan, from Spain, Europe, welcome. Yeah, Spain is in Europe. From USA, New Jersey, welcome New Jersey. I had spent some time in New Jersey during my training. It was a good time. Alberta, Canada, welcome from Alberta, Canada. Florida, welcome from Florida. And I have a license in Florida, so I can see patients there virtually online. Excellent. So welcome everyone, and we will talk today about the diagnosis of drug-resistant epilepsy. So drug-resistant epilepsy, this is a unique condition when you have seizures, as we said, that do not respond to medications. They continue to happen despite being in two or more anti-seizure medications. So how do we make the diagnosis, and what do we need to do? So first, the diagnosis will be clinical, which means that you talk to the doctor, to the patient, and evaluate and do the evaluation and know that the seizure type and epilepsy type and the medications the patient used, and the seizures continue. So let's talk about the exact testing that we need to use for drug-resistant epilepsy. So the first test we do, which is the most important test, and all epilepsy centers do that, it is called EEG or EMU. So EEG in the EMU, it is called Epilepsy Monitoring Unit. So this is a unique situation when we admit patients to the hospital, do long-term EEG, which means like hook them to the EEG, like put wires in the head with video in the hospital, and we start to lower the medications for seizures, have the patient have seizures, and then we record the seizures. We first know if the patient has epilepsy or not. And believe it or not, about 30% of patients who have drug-resistant epilepsy, we believe that they have epilepsy, drug-resistant. When we put them through that testing, they turn out they don't even have epilepsy. They have what we call psychogenic seizures, psychogenic non-epileptic seizures, which I have a whole series. You can see it in the playlist on the YouTube. So drug-resistant epilepsy that can be non-epileptic seizures. And then After that, if the patient has non-epileptic seizure, that's a different story. But if the patient have epilepsy, the EEG shows discharges, epileptic activity, excess electricity, then the patient will be diagnosed with epilepsy. And then we ask the question, is that what type of epilepsy we're dealing with? Are we dealing with generalized epilepsy? So generalized epilepsy is a unique type of epilepsy when the brain is built to seize, would you say? Like it's usually a genetic condition, the control of the electricity in the brain is high, and then you'll be having lots of discharges in the brain and causes seizures to happen. The generalized seizures, absent seizures, staring spells, and jerks. And this type of epilepsy is very important to know because not all medications for seizures work for that type of epilepsy. So it is very, very important to make the diagnosis so that you know what type of epilepsy you make. And the second type of epilepsy is called focal epilepsy. Focal epilepsy, when the seizure starts from one spot in the brain, usually there is a scar or cell did not form right or excess electricity in that area and causes seizures to happen in that location. So we know what type of epilepsy we're dealing with. If they deal with epilepsy or not, then what type of epilepsy. And then after that, we will map the brain where seizures are coming from. When the seizure starts, we will know where it starts in the brain, where does it spread, the symptoms that happens during the seizure. We'll do video monitoring there. We'll do heart monitoring. We do vital signs. We evaluate the patient to see if they are aware or not. So all these testing can be done during the epilepsy monitoring evaluation. It's a very, very important first step that based on that result, we will build all the subsequent testing. And then after we do the EEG monitoring and we know what type of epilepsy, what we are dealing with, then we go to other testing. Other testing can be brain MRI. So brain MRI, we take a detailed picture of the brain to know the structure of the brain, how the brain looks like, and to see, usually we do it with an epilepsy protocol brain MRI. So make sure that your doctor send you for an epilepsy protocol MRI. And the best one to be done with 3 Tesla. So the strength of the magnet is that like the megapixel of the camera. So there is usually MRI, which is 1.5 Tesla, 1.5 Tesla, and then 3 Tesla. So the higher Tesla, the higher the number, the better strength of the magnet, the more detailed picture it can take of the brain. And then it is done through epilepsy protocol, thin cuts and very detailed images and sequences. And then it is read by a neuroradiologist, somebody who is trained to read brain MRIs, and especially for epilepsy. If we do all of that, that is the best chances of capturing anything abnormal in the brain. We can see many things on the MRI, like we have a scar in the brain, mesial temporal sclerosis, MTS in the hippocampus, or we can see these small scars. Sometimes it's a stroke, sometimes there is like a blood vessel kinked or not formed right, or have like abnormal collection, like AVM, arteriovenous malformation, or cavernous hemangiomas. All these things are abnormal blood vessels, abnormal cells formation. Sometimes the cells do not form right in the brain, do not migrate all the way out to the surface of the brain. So the cells in the womb, when the brain is forming, they are in the middle of the brain, and then they migrate all the way up. Sometimes they do not migrate completely, and that causes seizures to happen. I have seen many patients with that. So all of these things can be clarified in MRI. And yes, MRI can be normal, and the patient has epilepsy in about 50% of the time. The second test is called PET scan. So PET is like positron emission tomography, which will do a CT scan with a dye. So there is a dye that has a fluoride emission, and like it's a nuclear medicine test with glucose, and then the normal brain cells will eat the glucose different than the epileptic cells, and then we can differentiate between them, so we can isolate where the seizure focus in the brain is, and so that will give us the function of the brain, and the brain MRI will give you the structure of the brain. So PET scan is very, very important. And then after that, we do MEG scan. So MEG scan is like one of the unique testing for the brain. It will detect the magnetic field. So it's called magnetoencephalogram. So this is the MEG test. So we test it's like a helmet that will take very, very sensitive, will detect the magnetic fields of the brain. And then we can detect that. There is a whole video about MEG scan. So we can detect the magnetic fields of the brain and map where the epilepsy function. And also we can map the brain function, the language, the vision, the sensory. All of these functions can be mapped through the MEG scan. And then we can do functional MRI. So functional MRI is a unique test that can detect the function of the brain, which means that, let's say that we are doing a surgery or we are dealing with an epileptic focus, like in the frontal lobe or paratemporal lobe or anywhere in the brain, and we are wondering like what is the function of the brain around that, so that we don't take any functional areas. So we can do functional MRI and map the brain functions, like map the sensation, map the language, map the memory, all of these things. And then also we can do WADA test. So WADA test is a detailed test for memory. So we detect the memory and language of the brain. So we inject a dye, and then after that we inject anesthetic. We'll anesthetize the left side of the brain, and then we do language testing, and then memory testing, and then we do the other side to see which part of the brain that is involved in memory and language, and that will help us to plan the surgery and give you counseling about like if there is any memory loss or issues after the surgery that's happening. And then also we can do a neuropsychological evaluation. It is a detailed analysis of all the functions of the brain in terms of language, memory. Like there are some different types of memory and brain function that we can test that can tell us, oh, there is a verbal memory dysfunction. It means that there is temporal lobe issues, and like executive function, there is a frontal lobe issue, and so on. And then one of the tests we can do is called ictal SPECT. So ictal SPECT is another nuclear medicine test. So we inject a dye, but this one, it will be a unique time. So the technician will sit next to the patient with the dye in hand, and then the second the start of the seizure, we inject the dye right away. So the dye will go into the brain, and then it will be utilized so much with the area of the seizure, and then the other areas of the brain will not take it as much. So we can make the differentiation, and then we can detect where the seizure starts in the brain. So all these testing are very important to put in like a pieces of the puzzle to differentiate like what type of epilepsy we have, where is it coming from, what is the function of the brain areas, and so on. And then after that, we sit down and we call like epilepsy surgery conference or multidisciplinary epilepsy management conference, and so on. So this is a committee that we sit down in a conference room. So we sit down together, the neurologists, the epilepsy doctors, the neuropsychologists, the radiologists, the neurosurgeons, neuropsychologists, everyone. So all the stakeholders in the epilepsy side team members. That's why we have an epilepsy center. We discuss all the data. We discuss the EEG, we discuss the MRI, we discuss all these findings. And then at the end of the day, we set a consensus of what is the best way to treat this patient. So it's a teamwork and a team decision rather than just one doctor. And then after that, we go to epilepsy surgery. So if somebody has generalized epilepsy, then usually we go to stimulation. But if they have focal epilepsy and then all the data is like one side of the brain, everything is concordant, it is not functional, there is only a scar, then we can do surgery. And sometimes we're not sure exactly which pinpoint the seizures start, then we can do what we call phase 2 monitoring. So phase 2 monitoring, we implant leads inside the brain, like we put wires, like needle electrodes inside the brain to study from inside the brain where exactly the seizures are coming from, so that we can better localize where the seizure starts, so we can do a more precise surgeries and try to evaluate the brain function around that area, so we don't take anything that is extra. So after that, we can do resection surgery. So let's say that somebody has temporal lobe epilepsy. It's like the perfect scenario. And then there is like a mesial temporal sclerosis. There is a scar in the brain. Then you can take that out, and that will provide an excellent treatment for seizures. And usually seizures will stop completely because of that very high chances. So usually the chances of seizures stopping completely with medications alone in drug-resistant epilepsy, we're talking about 1 to 5%. Very, very small chances. If we do surgery, for example, temporal lobe epilepsy surgery, it can be 50 to 80%. So that's a huge success, completely different than the medicine alone. So it is a hope that we can help patients with epilepsy with these surgeries. Of course, the success rate is different from one patient to another. It depends on the location of the seizures, if there is a lesion or not, if the MRI PET scan is normal or not. So the more things that are abnormal, like, there is a scar, cells did not form right, PET scan was positive. So the more positive things, the more likelihood that the surgery will be successful. And we can do the surgery through laser. So laser is a new treatment we can use. So this is how the laser looks like. So basically we put in a probe. So this is the laser probe, and then it will hit the brain, and it will produce local energy that can coagulate the brain. Like, it will hit the brain until it causes the local damage in that area. So instead of opening the skull and going inside, you can do the laser surgery, and that will save all the normal brain areas around it. So you don't have to open the skull and do the surgery, so much less complication rates. So this is called laser ablation. And then if laser does not work, or if we cannot do surgery, or there are multiple foci, multiple spots in the brain where the seizure starts from, then we're talking about what we call multifocal epilepsy, or like we don't know where the seizure is coming from. Then we can do vagus nerve stimulation. So this is the vagus nerve stimulation. So this is a device that is implanted in the neck. The wire will go in the neck up, and then the device itself will go in the chest, and then it will provide electricity to the brain to fight the abnormal electricity. The success rate of the vagus nerve stimulation is you're talking about a success rate of about like 5 to 15% of complete seizure freedom. About 50 to 60% of people will have success in stopping the seizures by 50%, which means that drop the seizure frequency by at least 50%. And then the seizures will be less frequent, will be less intense when they happen, and so on. So it is a helpful device that can be a choice for people who are not candidates for resection or surgery. And then other treatment can be deep brain stimulation. So deep brain stimulation, DBS, this is the device. Basically, the wires will go inside the head this time, will go in the brain and in the skull, and we'll do the surgery. We'll put in the wires, and then we'll thread them out, and then it will be in the chest. And this device can help also the same. We'll drop the seizure by at least 50% in more than 50% of the patients, and it will provide seizure freedom in like maybe 10 to 15% of the time. So it does definitely help. It's an option for people who have seizures, especially for frontal lobe or temporal lobe. And the last device we have is called responsive neurostimulation, or RNS device. So RNS device is a device that is implanted in the skull. So this is the device. We have the device itself, and that is implanted in the skull, and then the wires will go into the brain. We have depth electrode, which is like a needle electrode or strips that go on the surface of the brain, and then this device will be inside the skull. And this is how the device looks like. And then the device is smart. It will read the brain waves all the time. Will start reading the brain waves, and then when it sees a seizure, it will deliver a shock to stop it, small shocks that can neutralize the seizure. And then this device will get programmed by us. We review the patient multiple times. I have many patients with this device. It's very successful. It will give us the information about the seizures in the brain, and we will be able to localize where the seizures are coming from after that, like temporal lobe, like right side or left side. And then it will give neutralizing shocks to stop the seizures at the onset, and that will help a lot. And then it will provide us with data about the seizures and so on. So this is one of the good devices for epilepsy. Unfortunately, this device is only available in the United States, and there are studies and being introduced worldwide in Australia and UK and Europe. So hopefully the company will extend their coverage to go to the whole world. But for now, it's only available in the United States. I remember, we have, I work in Detroit, Michigan, so it's in the north next to Canada. So many patients from Canada will cross the bridge, and then they will come to US and implant this device because it's not available in Canada. Other treatments is the ketogenic diet. So ketogenic diet is a special type of diet that we can focus on, have high fat and high protein and very low carbohydrate. That will put the body in a starvation mode and produce ketones. And then these ketones will help with the acidity in the brain, and that will be anti-seizure. There's a whole video about that. It's called the best diet for epilepsy. And then, so that helps so much. It can help patients with epilepsy, and it's a very good choice. However, it's good for children. Adults have hard time, sticking to the diet because it's a very difficult diet to follow. I should say that ketogenic diet is something that we should be very religious on, like means consistent, taking it on time, and not changing the diet. Because if you get cheating days, like the athletes and other people get cheating days and weekends and get out of ketosis, that can be like stopping an anti-seizure medicine, and seizures will come back right away. Other medications that can be considered right now for the drug-resistant epilepsy is cenobamate. So it's a cenobamate, brand name is Xcopri in the US and Ontazri in Europe. This is a very good medicine. It helps so much with epilepsy. I have a whole video about cenobamate. You can watch it. But this medicine is very powerful, and it helps seizures a lot with much better success rate than any other anti-seizure medication. So now we change the way we do surgery. We give the medicine first, and if fails, then we go to surgery. But many patients, I have myself, canceled surgery because of this medicine. So I give them this medicine, cenobamate, seizures completely stop, so they don't even need surgery. So this medicine has very high promise, and that can help seizures. So there are few future treatments coming for epilepsy. I'm so excited about the future of epilepsy treatment. We have so many exciting treatments coming in the market. Now we have very precision medicine that can be like targeted treatments and so on. So these are the things that are really close to the finish line. There's a unique medicine called azithromycin. In the studies, it was XEN1101. It's from a Xenon Pharmaceutical in Vancouver, Canada. And this medicine is unique because it's a potassium channel opener. This is the only medication that works on potassium channels. And it works very well for seizures. It's once-a-day medication, have very good success rate and seizure freedom, and it is very good for compliance. Does not have any major side effects, does not interact with other medications, and it can be antidepressant and anti-anxiety. That's a very good option. So we expect that it will be available soon, in about like 2026, next year. Other treatment for epilepsy can be stem cell therapy. So stem cell therapy research is undergoing right now. Now it is in clinical trials. My center and myself are involved in the clinical trials for the stem cell therapies. So I'm excited so much about stem cell therapies because it is for the first time they have like embryonic stem cells that they can produce GABA and inhibit the brain excess electricity. We implant these cells inside the epilepsy focus, and then it will provide the treatment. So instead of taking medications, it will provide that locally, and then it will have a good response rate and seizure freedom. So I'm really excited about stem cell therapy. It has a good future. It's under clinical trials right now, so in a few years in the future, we'll have it in the market. And then the other breakthrough is gene therapy for epilepsy. We have now available gene therapies for epilepsy that can be very helpful, and then we can provide them. Now it is successful for Dravet syndrome. It's not like a gene therapy that changes the gene itself, but it will change the gene expression. So there is a technology called RNA ASO. So this technology, what it does, it will select. So we have two copies of for example, sodium channels in Dravet syndrome. One of them is bad sodium channel and one of them is good sodium channel. So what it does, this treatment will suppress the genes and the expression of the genes in the bad sodium channels and will enhance the normal genes. So the brain will be filled with normal sodium channels, and that's really good. And then we have now available online consultation. So I can help you personally by doing a consultation with me. It's very easy process. You can there is a link down in the description of this video. And then you can just go to the link, put your country, and then book up your consultation with the time that works for you. And we can even work a time that works for both of us. And then we will do a complete evaluation, review all the medical records, all the images and everything. We'll do a full evaluation for full 1 hour, one-on-one. And then I will provide you with a whole treatment plan that can work and what is available treatments and what we can do to help. I did so many consultations all over the world, from UK to Europe, Poland, even in New Zealand. There was like 15-hour difference. It was so interesting. It was like almost midnight for me, and it was the second day afternoon for them. It's really interesting. In Australia, in India, all over the world. So there are lots of potential for Middle East, for Arab countries. So we did lots of consultations. Everyone did the consult. They got lots of benefit and helped change their life and made the right diagnosis and right treatment for them. So feel free to book your own consultation, and then we'll see you right away. And now my favorite part of this live stream is the questions and answers. So we'll do direct interaction. So please write your questions, what you need help with. So for us to be successful, the best way is to write the question only once. I will go from the beginning of the live and go all the way through the questions. So ask your questions once, and then please make it short and precise and ask about one thing rather than just explaining your whole case, because sometimes I cannot read through the whole case and cannot provide medical advice. And please write the generic names of medications so that I don't know like all the local names, because sometimes the companies make different names for them. So please do that. And then let's start with that. So Well says, what is your experience with RNS surgery and how quickly you have seen changes take post-surgery? So Excellent question. We talked about RNS in this video, and so RNS is it's called responsive neurostimulation. This device will, as we said, we read the brain activity and then will deliver discharge. So first of all, we implant the device, and then after the device is implanted, we get a period about like a month or so of just recording the brain, and then after that we'll start to activate the brain, and then usually we start to increase the electricity of the treatment every 3 months, increase gradually. We aim to go to 2.5 of charge density, like treatment, how much it gives. So we usually achieve that in about between a year or like 6 months to a year. So it's important to kind of like, it takes time to reach this treatment. So we expect to see changes within 6 months to 12 months of the treatment. And then usually things can get better with time as well. Yeah, so Pandit said that I have problems since 2010 and drugs causing problems. Please help me. Yes, so that's a whole video about is to help you with the information that you need so that you can discuss with your doctors and so on. So the question is that the patient has a daughter that has seizures for 5 years old now, and she's on phenobarbital, causing lots of side effects and seizures. So yes, this is unfortunate case. Sometimes that medications can cause side effects, and phenobarbital is one of the oldest medications we have for seizures. It does have so many side effects. That's why we don't use it anymore, except when you don't have any other options. So there are newer anti-seizure medications that can help without this side effect. So ask your doctor for switching her to something different, or if we can do any surgical treatment and so on. So also she's on Fintepla, sodium valproate, clobazam. So Fintepla is a medicine that can be used in for Dravet syndrome. So maybe she has Dravet syndrome or one of these genetic disorders that can cause issues with that. Okay. Okay, so we have all medication make degraded and severely aggressive. So yeah, so lots of side effects from the medications can happen. Some of the medicine that can cause lots of side effects are the medicine that is like the most notorious for aggressive and side effects, psychiatric side effects, is Keppra. So make sure you're not on Keppra, because that can cause lots of side effects. Also, Ficamba, Perampanel, they both can cause lots of side effects. All right, and then okay, so let's go to more. See, I absolutely love watching your videos, and it's hard to live with epilepsy, temporal lobe. Yes, thank you so much for your participation, and definitely that's my honor that you enjoy the videos, and that's my mission too, so that we provide you with information that you can help yourself and your loved one to have better care of your seizures. And then many patients said, like, I go to my doctor now with lots of knowledge, and then I can discuss with my doctors much better, like how I can help myself. Says I have brain abnormalities on the left side and have deep scarring. Yes, scars can cause seizures and can cause temporal lobe epilepsy. So the question is about the transcutaneous VNS. Can the transcutaneous VNS be effective? So here's what I can say about that. So transcutaneous VNS is a vagus nerve stimulation that can be delivered transcutaneously, which means that not implanted device like the one I showed in the neck, but they can do it through the skin, either through the vagus nerve itself in the neck or through the ear. It can deliver the stimulation. This device, the studies on that, when I studied it and looked up the research, it is not really effective. So I don't think it's really worth the try. But if it's feasible and available to you, there's no harm in trying it. But I don't have high hopes that it will be very helpful. So counting the 2 meds, and then so I have been through 11 medication, and I have the RNS system too. Yes. So usually when patients have drug-resistant epilepsy, they go through multiple medications because every medicine fails. So yes, so you cut that short by going into surgery right away, and then that is the more definitive treatment. If we cannot resect the area, then we can put an RNS stimulator device that can help. And in the future, maybe stem cells will be available, maybe other newer medication that can be done and have better results. Yeah, so son is 14 years old and having seizures despite being on valproic acid, lamictal, and oxcarbazepine. Yes, it can happen when seizures continue with at least 2 or more medications for seizures. And this is the definition of drug-resistant epilepsy. I hope you can follow through the plan I laid out today to can help you and your son with the seizures. Yeah, Cornel, thank you so much for your informative video. Welcome. Thank you so much for being here. So the question about, do I know doctors in Arizona? Yes, Barrow there. So there are multiple epilepsy centers in the area. And definitely, so your guide is that if you go to the Epilepsy Foundation of America, they have the list of all the epilepsy centers. So you can go there. And yes, the ones that you mentioned are epilepsy centers. So that's really a good thing. Okay, some people are asking each questions. Yes, so levetiracetam made me a raging monster. Yes, unfortunately, that's what I say a lot in my videos. Levetiracetam, Keppra causes lots of rage and other issues. So definitely should be avoided if anyone has any, history of psychiatric conditions or even any side effects with that. So it should be stopped and then transferred to something else. I had TBI as teenager, and then I had about 30 seconds long partial sometimes, and mainly bad grammars that medication are done, nothing to stop. What are the odds it's PNES? Well, as I said, that about 30%, I'm not talking about you, but just in general, about 30% of the people who have thought to be epilepsy, when we bring them to the monitoring unit, it turns out to be non-epileptic seizure. So I cannot say for you what is the diagnosis, but I can tell you what to do. So what to do is to go to the epilepsy monitoring unit, like go to an epilepsy center, ask for an epilepsy monitoring unit evaluation. Then you will have the seizures, and then we'll see in the brain if it has electricity excess, which is epilepsy, or not. Then it will be non-epileptic seizures, PNES. And I have a whole series about PNES. You can watch it for more information. Jacob has excellent question about what is your thoughts about the focal autonomic seizures. So focal autonomic seizures are seizures in the brain that happens to have autonomic symptoms. For example, if somebody has a seizure, so I think of seizures as like turning the switch on. So whatever that lamp or that light is connected to, it will do. So for example, if you have a seizure in the vision area, you will have flashes of light. If you have seizures in the memory area, you will have deja vu. If you have seizures in the emotional area, you have fear or sadness or so on. So if you have seizures in the autonomic control area, then you will have autonomic symptoms. Some people have racing heart, some people have sweating, goosebumps is a sign of seizures in that area, and so on. So all of this can be autonomic functions. So it depends on the area of the brain that is activated during the seizure. Eslicarbazepine, cenobamate, yes, these are good medications for focal epilepsy. Okay, I'm going through some people talking to each other in the chats. I'm trying to figure out which one is the question. Okay, so the question is that somebody has a VNS surgery done. When do we expect to have results? So usually the results of the VNS or any implantation device, it happens it depends on how fast you went up on the titration. So for example, we need to reach in the VNS to a number 1.5 at least of electricity. We start with 0.25 and then 0.5 and then 0.75 and then 1 and then 1.25 and then 1.5. So it's important to keep going back to the neurologist, programming the device. And now luckily the device can be advancedly programmed, which means that we can set the device up to go on its own to every 2 weeks to increase the result. So it's important to reach the target dose. First of all, it's very important to reach the target dose of 1.5 to 1.75. And then after that, if the seizures continue, then you can tweak the other settings to make it very frequently cycling, called rapid cycling. That is how we can do the VNS. And then there's a whole video about VNS. I recommend you watch it. But the time we expect it to be within like 6 months to a year, within, and also reaching the target dose. So that is the time that we start seeing good results with that. Okay, so I'm looking for okay, so many people are just talking to each other, so trying. Okay, so Naima says that the 6-year-old experiencing drop seizures once a day, and while he's taking lamotrigine, Epival, eslicarbazepine, and clobazam. So that's an unfortunate case of that. Patients likely will have the diagnosis of likely it will be so either Dosey syndrome can cause drops, or usually it's called Lennox-Gastaut syndrome. So Lennox-Gastaut syndrome is one of the types of epilepsy that patients have drop attacks. They fall, and for example, sometimes that eslicarbazepine, it's kind of generalized epilepsy, so it does not work very well for this generalized type. So maybe you can discuss about the doctor about that medicine. But overall, the treatment can be either vagus nerve stimulation, or we sometimes do corpus callosotomy and have them have a helmet because it's a very severe type. So which country is offering gene therapy? So at this point, the studies of gene therapy are still not available for treatment. They are under investigations and research. So we have lots of trials being done in the United States and hopefully worldwide as well. There are some companies that are doing in France and other areas of the world. So definitely it is a worldwide effort so that we can collect data from all over the world and have it available in the market. But so far, there is no available treatment for gene therapy, but it is being studied in the market. Okay, so looking at a question. Yes, so the question, how can I call you? Yes, you can do that. So I don't have like a number you can call, but what I say is that you can book a consultation. So there is a consultation availability right now. So there is a link down below in the description of this video. You can go to the link, just go there, get the country, and then book your own consultation. It's very easy. You can do it on your own. And then once you book your consultation, we can have a one-on-one evaluation and so on. Okay, I'm trying to find the questions, and some people are talking to each other. So the question is that is nocturnal tonic-clonic seizures cured? There is a whole video called Nocturnal Seizures or Nighttime Seizures. That's a helpful video that goes in depth about this condition. However, nocturnal seizures are seizures that happen during the nighttime. Usually it is focal epilepsy, and generalized epilepsy even can do that. So the treatment is like any other type of seizures. We give medications, and then if it is resistant, we can do surgical treatment for it. Okay, so I'm looking for more questions, cluster of seizures. Okay, so the doctor said my son is 7 years old, 6 years old, cluster seizures while weaning off Keppra. His neurologist said this isn't due to medicine withdrawal. Have you heard of that happening? All right, so I cannot answer this like case based on the case itself, but just this is in general information. Don't take it and go to the doctors like, oh, I want to. So in general, if we have seizures that are controlled on medications in kids, some doctors elect to lower the anti-seizure medications and stop them. However, that will put them at risk of having seizure recurrence. Depends on the type of seizures and the evaluations and how many seizures happen, all of that. There is a whole video about stopping anti-seizure medications. For kids, it's different than adults. If we stop the seizure medications, then seizures can come back, and then that will be due to the stopping in the seizure medications. But it is hard to say for sure like what is the cause of the seizures. Okay, so yeah, Eric said, thank you for the super chat. Do you have any insights or medical opinion on FDA-approved devices such as EP Watch regarding their efficacy for temporal lobe epilepsy? Yes. Well, thank you so much for the super chat. Yes, I have done a whole video about the devices for epilepsy, the detection watches, and so on. So there are two devices definitely right now that are detecting seizures. So the Apple Watch can be turned into a seizure detection watch by installing apps, Seize Alarm and other ones. I tested them, was not very accurate because the device was not made to detect seizures. The other one is Empatica. They did Embrace 2, and then now there is one, it's called EP Watch. These are devices that are made to detect seizures. They're very effective and they're good. However, we should understand that these devices have sensors for movements called gyroscope. So gyroscope is a sensor for movement, and then they have sensors for heart rate and skin conductance, which is sweating. So all of these things happen during the seizure. So when shaking happens, the device can detect the shaking, and then with that, it will be some sweating and will be other ones. So that's important things that you should know, that with people with epilepsy, they can have shaking, and then they have been detected by the watch. So it works for seizures that are convulsive seizures only. So when it's shaking, so if the patient has shaking seizures, the watch will do very good and it will detect it. But if the patient has focal unaware, like focal intact consciousness, which means that they will just pause and they will pick on themselves, they turn their head and then they stop, the device will not be able to detect it, because the device is designed to detect movement. So that's what I would say about this. And definitely I will consider, like, highly recommend for you to go and see the video about that. All right, so and then Miles, thank you so much for the super chat. I 16 years having less full or more partial neuroplasticity. So I don't understand the question 100%, but so which means that there are seizures that are happening with there are partial seizures or full seizures, and then what's neuroplasticity? Neuroplasticity, it works for people who have seizures, that it can engage other areas of the brain, and especially like stem cells can be induced in the brain that can cause seizures to happen more. So every seizure in the brain can trigger another seizure. Seizures beget seizures. That's what we say. So seizures will trigger more seizures, will strengthen the network in the brain and makes it harder and harder to control. Okay, so let's go to more questions. So if you can, like, when you put a question mark before that, so that I know that this is a question, it's not people talking to each other. Okay, so let's go back to the questions, and then so I forgot. Okay, excellent. Encephalitis. Okay, so I have a brain surgery in January to remove a tumor on my left side of my brain in the front. However, Stanford did the wrong surgery and I ended up with a subdural hemorrhage and blood clot. Will I heal? Okay, so it's hard to say anything about a specific case, especially complications happen and so on. So don't take it this like, oh, go to Stanford. It's like, oh, Dr. Danoon said this. So what I can say is that when you have a tumor surgery, it's different than epilepsy surgery. So tumor surgeries, there's a tumor in the brain, and there are different stages, locations, how deep it is, and so on. So there are multiple factors to play here. Where is the location of the tumor and what types and so on. So it depends from one person to another. Hemorrhage, subdural hemorrhage, all of these are known complications of any brain surgery. So it is not unexpected to have brain hemorrhage and subdural hemorrhage after tumor surgery. So it is one of the known complications, and usually the doctors will tell you that there are complications that can happen. Bleeding is one of them, and so on. So sometimes it's expected to have some hemorrhage and other complications from the surgery in the brain. Blood clots can happen, maybe in the legs, usually it can happen, or so on. So it's kind of a case by case. And will you recover? I hope so. That the brain is very plastic, means like there are ways for recovery. Even strokes or brain tumors, they tend to recover and improve with time. Okay, more questions. Yeah, so we talked about the Epi Watch. And so what are the side effects of the RNS implantation? So usually the side effects are minimal, and most of them go without side effects. However, any surgery, as we just said, any surgery in the brain can have side effects. It can be like implanting leads in the brain can cause bleeding, small risk. There can be breakage in the lead themselves. It can be infection, bleeding, all of that, brain damage, nerve damage. All of these things are potential side effects. Luckily, the side effects profile is low, and they are considered overall safe surgery. All right, so Paul asked, my son has tonic-clonic seizures, no issues in the brain, nothing found in his DNA. Yeah, so they did eDNA, everything was good. His keto diet and using clobazam and Epidiolex, we don't know what else to do. So yeah, so sometimes the difficult cases, it's hard to give specific recommendation without knowing the case. But what I would recommend is always go to an epilepsy center so that you make sure that you have the best care pediatric epilepsy doctor. They provide the best care for your son, and then and then if the seizures do not stop, like in your case, then other surgical treatment can be helpful. Sometimes like vagus nerve stimulation, other surgeries. So discuss. That's why you need to be in an epilepsy center so that they can have more treatment option than just medicine. Excellent. Tan said that my 2-year-old has generalized epilepsy, 18 seizures since last September. A lot of seizures, MRI and ECG are normal. He's on Keppra, midazolam, and Keppra shortened seizures, but still has them and worsens with his autism. It's nonverbal. Yes, unfortunately, yes. Some cases, like with autism, there is higher risk of seizures. Happens about like the kids with autism have about 30-fold increase of risk of seizures. So definitely there is association between these two, and then they are often having resistant seizures. That's a risk factor for resistance in seizures. However, if the Keppra, for example, does not work, Keppra usually causes also behavioral side effects, so we should avoid it. Like we better avoid it. Not that's in general, not in your son. Just discuss with your neurologist. So this is not a medical advice. This is just information in general. So if a medicine does not work, try to other medications. We have multiple medications that can work. So they have autoimmune encephalitis. It's never going away. Yeah, that's right. So autoimmune encephalitis does not go away. However, it can be managed. So autoimmune encephalitis, when the brain like the body immune system, the white blood cells will attack the brain as a foreign thing. So it will start to attack the brain and cause inflammation, and then seizures and behavioral changes and psychiatric. So the lots of things can happen. Depends where the inflammation is in the brain. So yeah, this can happen in the brain because of it. Okay, so using Keppra and Lamictal for 6 months, but still having focal seizures. Doctor wants to replace Keppra with Perampanel. Do they have work well together? Thoughts? So okay, so two things here. So first of all, that we know that Keppra causes psychiatric side effects, and then Perampanel, Fycompa, causes more psychiatric side effects. So if the issue was psychiatric side effects, it's anger, mood changes, irritability, then Ficomba makes things worse than better. If the patient does not have any psychiatric history, psych is good, everything is good, chill and fine, then Ficomba works in a different way than Keppra and lamotrigine, so it can provide a better option and it can be done. It's always a doctor decision with the discussion. Okay, so Kim said that I have VNS surgery 2 years ago and generalized tonic-clonic seizures, no seizures for 6 months afterwards. Now I'm having more seizures and more severe than before. So there was a dormant time of seizures improvement and then now got worse. So why seizures can get worse? There are multiple reasons why seizures can get worse with time. Overall, seizures tend to get worse with time than improve if they're not treated. Even with treatment, sometimes they do that. So it's kind of like they dig paths in the brain. So for example, somebody has like a small road and then now it's local, people walk, and then with time it will become a big road and then will be a main highway afterwards. So that's how seizures dig themselves in the brain. They will engage themselves in a network and becomes very established and becomes harder and harder to control and more resistant. So that is the type of, sometimes medication and compliance, sometimes other things, sometimes stress in life. So there are so many types of like why the seizures can get worse with time. Okay, how can we say that the patient is seizure-free, especially for infants and toddlers continue to take medication? So when somebody has seizure-free, means like they stop having seizures. So you can watch them and they don't have seizures. That is seizure freedom. And then the decision to stop medications is completely different in children to adults. Depends on the type and what causes the seizures. Is it something permanent that's going to go away with time and so on? So there are many things that we can factor that. Yeah, Dr. Arun, did you say that stem cells therapy uses human embryonic stem cells? Yes. So there, it is derived from human embryonic cells. So it's kind of like one of the cell lines that people use in research. And these are small cells that are like really not differentiated. And then they use that. So it's so the company that makes, so there is like a discussion about that, like a human embryos or not. I don't think like I'm not aware of the exact technique, but they harvest small cells. So I'm not sure like if they take it from embryos, humans, or it's something that is in the beginning of life, but it is an embryonic stem cells. So we can talk to the company more about like where is the onset of that. And there are lots of regulations, by the way, about research for human embryos and so on. Yes, so my daughter has 39, has LGS, Lennox-Gastaut syndrome. As I said, this is one of more difficult conditions to treat. It's one of the most difficult types of epilepsy. Patients usually have many types of seizures. And then unfortunately they have falls and then they hurt themselves. There are many seizures daily. So yeah, definitely this is something that we encounter and can be very difficult to control. Sometimes corpus callosotomy or VNS can help, but not. What do you say about triliptal and to seizures? Yes, so there is a whole video about triliptal. I will recommend you go see it. It has all the information about this medicine. So definitely it's a medicine that can be given for focal seizures, but can worsen generalized epilepsy. So what are the side effects of LIT, laser ablation? So the side effect of laser ablation mostly are minimal, but it's related to the surgery itself, like small chance of bleeding, small chance of infection. The hole is really small and the device itself is small, so the chances of like causing damage is low. It can, in the mesial temporal lobe, it can affect the vision because the tracts go there and then sometimes they can be affected. Other things can be because of the surgery itself, like if you have a damage to like memory area or so on. So it depends really on what is the location, but it is much less side effects than open surgery. Okay. Okay, so yeah, so asking about weather conditions. Okay, so asking about weather conditions. Thanks for putting question mark, because some people talk to themselves. So I don't know if that's a question or not. Asked about weather conditions. I should clarify that I had craniotomy, um, millivirastam, topiramate. I have VNS. Is there any better medication? So as I said, that there are newer medications like the cenobamate can help a lot. So maybe discuss with your doctor about that. And then coming medications in the future, like the medicine we just talked about, the azithromycin, hopefully next year will be a good option. Is Kebra affects the CK level? CK level is that this is the enzyme that happens from the muscles? Likely, no. Okay, so I'm trying to find small questions that I can answer before the end of this. So how to determine if the patient has drug resistance? As I said in the beginning of the video, that drug resistant is when seizures do not respond despite being on two medications that are appropriate for that type of seizures. So I'll be alive. I'll be on live stream tomorrow as well, and we'll see you tomorrow, and we'll answer more questions if you have any questions. Thank you so much, and you're my favorite doctor. Thank you so much. So we'll ask. I want to book an appointment. Thanks. I am in the process of being diagnosed with reflex epilepsies, familiar paroxysmal casogenic dyskinesia, or both. Definitely, yeah. So Alfred, yeah, more than welcome. I can definitely help you. Feel free to book an appointment, and we will do the evaluation and then help. Okay, last question. My son has epilepsy from 2018. How to diagnose and which type of epilepsy is it? Seizures are not stopping even for medication. So yes, if somebody has seizures, what type of epilepsy? Usually the type of seizures, how the seizures look like, the EEG evaluation, the MRI evaluation, and the overall evaluation. This is all we have to evaluate the patient with epilepsy. And then after we do the whole evaluation, we decide what type of epilepsy. And then the epilepsy monitoring unit, as I said in the beginning of the video, will diagnose what type of epilepsy we have. And then based on that, we will guide the treatment. Tomorrow we will announce the time. And then having a bad cluster of seizures, clobazam or buccal midazolam. Yeah, so we can do that. Clobazam can be given to prevent the clusters if they're multiple. Also, buccal midazolam can be help to stop the seizures. Sometimes nasal diazepam, nasal midazolam can also help. And this video helps more about the epilepsy surgery. You can watch it and stay healthy, and see you on the next one. Salam.